Assalamu alaikum. Last week, I had experienced some pretty grueling asthma attacks. I was I had asthma as a kid, but for about the last 10 to 15 years, I haven't actually felt the effects of asthma. Although I was kind of sometimes in and out of hospital as a kid with it, I kind of thought I was cured. And it's relevant for this episode if you hang on with me for a second. What ended up happening is about 10 days ago, I had an asthma attack. I recognized it pretty much straight away because I remember the feeling as a kid. It kind of feels like you're breathing through a straw and you're really struggling to get breath. Stupidly, I didn't do anything about it, but then I did have another asthma attack a few days later, and then I had a third, so about 3 in the space of like a week. When I had my second, Kaya, may Allah bless him, who you guys know is my co-host here, took me to the hospital and they put me on nebulizers and medicines and ECG, and I had a chest x-ray just before. Basically I was on like 2 or 3 different, I was basically taking nebulizer every 2 hours. I was on loads of different medications, but things didn't really seem to be getting better. And at that point, I started looking for someone who specializes in asthma, which I later found out to be pulmonology, which is kind of the study, the medicine specific to kind of breathing and lungs and all that kind of stuff. And I came across this expert out here called Dr. Fawzi Katranji. And so I thought, I'm going to book a consultation with this guy. I booked a consultation with him, and honestly, it was the biggest relief. I finally felt like I was speaking to someone who understood my problem, what I was going through. He gave me a more advanced inhaler and some tablets to take, and it just felt like I was he ran tests on me, but it felt like I was speaking to someone who understood what I was going through. He drew diagrams for me and helped me understand what's going on in my airways, and I ended up asking him to come on the podcast. He very kindly agreed, and this is a really powerful episode for anyone who is, has got asthma or breathing issues, but also he's an expert in sleep. So sleeping disorders, psychology as well, sleep apnea. So if you are interested in sleep, if you're interested in breathing, if you're interested in psychology, I think you're going to love this episode. Before we get into the episode though, I want to tell you guys about IOU, the International Open University. International Open University is an online university where you can study from the comfort of your own home, and is Islamized education. That means that the degrees that you learn are taught by Muslims, and they take the Muslim lifestyle into consideration. So you can still get a degree in things like business, Arabic, psychology, and they're accredited degrees, actual undergrad degrees, master's degrees that you can get, but you don't have to sacrifice your morals or ethics when you learn them. And also, you can learn from the comfort of your own home, in your own time, whenever you want and however you want. IOU has been phenomenal in helping many Muslims around the world. And right now, if you enroll right now, I think there's literally about a few days left if you're watching this when this episode comes out. If you sign up in the next few days, you can get 10% off by going to iou.edu.gm/FG. You get 10% off your first semester fees. So please do hurry if you are interested. Get in touch with them and get that degree. Assalamu alaikum, Dr. Fawzi Katranji. How are you doing?
Very good. Assalamu alaikum wa alaikum assalam wa rahmatullah. How are you doing, Faisal?
I'm
nice
very
to meet
well.
you.
Yes, lovely to see you too. It's only the second time we've met, but I've been so excited for this episode. Honestly, I'm really, really excited to have you on.
No, thank you very much.
I really appreciate your time. It's an absolute honor and a pleasure to have you. And when I was thinking about the episode, I was thinking, where do we begin? Right, because there's so much that I want to go into with you. And then, whenever you think about where do we begin, I think the best place is always the start, right? So I wanted to start with your kind of education journey, kind of with where you're at now, and I'm going to dive into sleep apnea, children's sleep behavior, and then breathing, asthma, and so on and so forth. But before all of that, it all started initially with a psychology degree, right?
Yeah.
So why psychology?
So in the USA, before you become a doctor, you have to do what we call an undergraduate degree. So after high school, you get into college, and I went to University of Michigan, and I chose the stuff that I'm most interested in. Now, there was a time where I was interested in law and potentially becoming a lawyer. And so I thought psychology would be great, and I thought history would be great. So I got 2 degrees. One is in Near Eastern history, and the other one is in psychology.
Oh, wow.
And so, psychology and history have been with me, ever since. It's just the passion that you have. So it kind of built kind of an understanding of who I am. I would tell you that, I think one of the things when we grow up as young Muslim kids, a lot of times you feel like you have religious understanding and you have Allah subhanahu wa ta'ala. But I think when you study the mind, you study your thoughts, you study psychology, you start to kind of understand things about yourself on a deeper level, like how your relationships are built, what type of relationships you have, how it's informed by, your parents' relationship, your brother's relationship, your relationship with your, community. So psychology is everything. It's I think most of the time I think we talked about books earlier. 99% of the books, when you read them, you think about the characters, you think about their development, you think about the psychology of the warriors, the sultans, the money makers, and it starts to make sense. The world starts to make sense, and I think psychology helps you do that.
It's interesting because when I saw you last week, I asked if stress can kind of be a factor in certain illnesses. I was obviously speaking pertaining to asthma at the time, but the answer you gave me I thought was quite interesting, especially coming from, I suppose you don't expect it from a doctor, which is weird to say, but you said to me, I don't know if you remember, you said there's a really deep connection between the mind and the body. And the example that you gave was, if I told somebody that their family member has had a heart, no, if I told somebody that their family member has died, depending on kind of the time I tell them and their situation, they could have a heart attack. And I found that really interesting. Again, more so because I suppose your expectation from a doctor or a medical doctor when you're speaking to them tends to be, okay, that they're going to talk more from a science perspective, not necessarily like a social science perspective. And you gave a different take on that.
Yeah. I when you say that, it doesn't occur to me that that's something unique or special, but I would tell you that 100%. We know that, for example, depression is a comorbidity. Comorbidity meaning that if you have any disease or any issue, and you suddenly, you struggle with any kind of psychological issue, depression, classically, whatever that disease is worse. So, there is a disease like, for example, I think Takayasu arteritis. Now I'm a pulmonologist, so I might be wrong cardiology, but I think, Takayasu arteritis is literally where your heart becomes inflamed. One of the vessels becomes inflamed due to stress, emotional stress. We know that asthma, people say, Doc, I'm more anxious. I have a lot of anxiety. I have more people saying that they struggle with anxiety than they tell me that they're short of breath, asthmatics. So you kind of start to make that connection on a regular basis, that 100% people's feelings, people's emotions is very, very directly linked to their psyche.
I remember
when health,
when I was really little, I would, if I was having like an episode and with my asthma, and then I remember that you would go, my parents would call the ambulance, and then the paramedics would come, and I'd be, hyperventilating, and then they take me to the hospital because I'm a kid who's struggling to breathe, right? So it's like, even if we think you're going to be fine, like the, rule book is, he's a child and he's struggling to breathe, you have to take him in. They would take me into the hospital, and then even then the NHS wait times were so long, and so then I'd be there for like, so I remember sometimes, you're there all night, 5, 6, 7 hours, and by the end of it, I'm actually breathing fine, and I just kind of like go home. And what that made me realize is that the panic. So there's like having what we colloquially, I suppose, call an asthma attack. Do you in the medical field ever call it an asthma attack? I've not.
Yeah, we call it attack, but I guess more technically we'll call it an exacerbation of asthma. Yeah.
So I noticed that I was having an asthma attack, but then an asthma attack plus panic attack makes you breathe it makes your breathing even more difficult, and then you start panicking, you're hyperventilating, and it's just everything's so much worse. So now as an adult, as soon as I start feeling an asthma attack coming on, my go-to protocol is to calm down. And it doesn't mean that the breathing is going to get fixed, but it's definitely not going to get fixed by panicking. And so the most recent one I had of I want to say like the day before I saw you, so it was like last Saturday night. At that point, I said to my wife, it sounds so weird, but I said to her, feel like I'm having an episode. I'm really struggling to breathe here. I said, can you just come and sit with me? She was putting the kids to bed. She was like, okay, fine. So we just spent an hour, just sat together. And I was like, just talk to me about something that's not to do with my breathing. And she spoke. And I, at the time, was struggling so much I couldn't even speak. So I was just like saying to her, talk to me. Like, just talk at me. And eventually, I'm not saying this cured it, but it definitely did help me calm down, which was a big help. And then, yeah, over time, again, I started being able to kind of get the pattern back and stuff like that. So
yeah,
I can see the link.
Yeah, 100%. I think that's a sign of a healthy mind, in my opinion, that you can actually kind of recognize the danger and you know exactly what you need to do in order to get through it. So it's kind of beautiful. One of the things, when it comes to those things, and I'm sure maybe we'll talk about it in the future, but it's that breathing. I tell people usually the issue is they can't take in a breath, right? They're having an anxiety attack because of what I describe as air hunger, right? I can't take in that next breath. And ultimately, the reason is you're not exhaling very well. So one of the things you can do to help you calm down is to actually do the opposite of what you think you need to do, is just kind of empty out your lungs to give your lungs the opportunity to take in more air. And usually once people do that, so just exhale for a little bit longer. So if it's normally a 2-second exhale, give yourself a 3-4 second exhale. Then take a next breath. You'll see that next breath is a little bit deeper. Ultimately, you need an inhaler, you need medication, no doubt in my mind. But that anxiety can be controlled a little bit by your breathing and by the kind of social interaction, the positive social interaction you have with your wife, which is really nice.
Amazing. Okay, so you mentioned inhalers. So what I want to do now is I kind of want to zoom into asthma a bit. So I'm going to go back to kind of first principles. I want to know, first of all, what is asthma? And then secondly, how specifically do inhalers help? Because in the UK, we usually get given, or the most commonly when I speak to people, and in my experience as well, we'll get given a blue inhaler and a brown inhaler. You're given the blue inhaler at first, and they say, if you are struggling to breathe, take a puff or two of the blue inhaler. But then if it continues to go back, stay bad, you might come in for another consultation and they'll give you the brown inhaler. The brown inhaler, usually they say take it, twice in the morning, twice in the evening, and that should help kind of longer term. So from a basics perspective, I think this will help a lot of people who have asthma or who know people who have asthma or whose children have asthma. Can you break down what asthma actually is and then what those inhalers are meant to do, and if if that is the best kind of course of action?
So I think giving that history, you can, for me, I can reflect on how even as pulmonologists, our understanding of what asthma has changed dramatically. So historically, we give the blue inhaler, and it's usually, in America, we call it albuterol. Here, we call it Ventolin, and it is a bronchodilator. It's something that opens up the airway. Excuse me.
No worries.
So what you understand is that asthma is an airway narrowing to the point where you take in a breath and you don't exhale properly. So you're unable to breathe out. The blue inhaler is a bronchodilator. It opens up the airway and it helps you exhale. It helps you breathe. Now what we're realizing is that it's probably a bit of a mistake. So the blue inhaler is going to go by the wayside, and they're going to have an inhaler that has a steroid in it. So that's the brown inhaler, the ICS. Because asthma, ultimately, for most people, is an inflammatory process of the lungs, of the airway. And that inflammation goes away with something called an inhaled corticosteroid. So a steroid. And you need, every single time you have an attack of asthma or an exacerbation of asthma, you need something to not just open up the airways to give you that immediate relief, but you need something to calm down the inflammation, and that's the steroid. So I would imagine in the next few years that when whatever happens in the NHS, in the USA, here in UAE, that standard is going to change. Our understanding of asthma, it's an inflammatory disease that needs an inhaled steroid to reduce the inflammation. This inflammatory disease of the lung causes airway narrowing, and people become short of breath and start gasping for air.
Airway narrowing is a very visual description and makes a lot of sense to somebody like me. And I expect a lot of people who have asthma, because the best way I've heard asthma be explained is it feels like you're breathing through a straw.
Mm-hmm. Yeah.
When I heard that, I was like, that's exactly like someone's powerfully explained how I feel. And I actually wanted to draw this diagram for you, actually, because that day when I was with my wife, I was trying to explain to her what it is that I feel, because I think for somebody who's not going through it, it's very difficult to explain. And also, when the go-to thing that I say is I can't breathe. But I don't mean I can't breathe, because if I couldn't breathe, I wouldn't be right in front of you, right? So I can physically breathe, but it's the best way of me quickly being able to explain what's happening, right? And so that day I said, okay, this is what I actually feel like. So part of the thing that I said, and I want to know if this, because I don't think I've explained this to you. Part of it was that I felt like you breathing through a straw. The second thing, the way I explained it is I drew this. I basically said, and so for those of you who are listening, I'll try and describe the drawing. So I drew like a line like this. So this is like a line that goes slightly curves up and then like comes back down. And it's like a long line. This is how what I explained. I said this is like a normal breath, right? And when I'm going through an asthma attack, this is like a deep breath. So I kind of want to take a deep breath and come back down. This feels really good, right? I explained to her this feels really good. But the bad thing about asthma, having an asthma attack, is that sometimes I have to time these deep breaths because I don't feel like I've got enough energy to pull one of these quite often. But if I do pull this, it feels great for a few seconds. And so I say that sometimes what can happen is I'm trying to pull a deep breath, but I only get to here. I peak, but I don't come down. And then I come back down this way. So I don't go over the deep breath. And that feels even worse because now not only have I not got the feeling of the deep breath, but I've used my energy.
Right.
And then I said to her that when I'm going through an asthma attack, I'm usually breathing like this from here to here. So, that's a full breath. I'm breathing from here to here. But then if I try this and it doesn't work, then now I'm breathing from here to here. And that was the best way I could explain it. And she understood. And I explained to my parents, I was like, this perfectly explains how I feel. So how does that look to somebody like you who actually knows the science behind it?
So, I mean, it looks right. I mean, ultimately what you're doing is you're stacking your breath. Maybe I can see if I can draw with you.
Yeah, go ahead.
Yeah. All right. So just kind of taking back on this theme that you provided for me, you have something called, inspiration and then exhalation, right? So you're basically telling me that, Doc, this part feels bad, this part feels worse. So what we want you to do, so what's happening is this part, you're inhaling, but you're not able to exhale. So whatever you're taking in, you're not able to take out. Actually, let me draw it in a different way, if that's okay with you. All right, so let me see. So here's your trachea, and here's your airways, all right? Here are your airways. The airways get smaller and smaller until you reach something called the alveoli. So your lungs look like a tracheobronchial tree. Here's your heart, all right?
Sure.
What's happening is ultimately there's inflammation and your airways are narrowing. So this airway becomes narrow. So it's hard for you to breathe in, but more importantly, it's hard for you to breathe out. So this exhalation part, you cannot breathe out. This air becomes trapped. You depend on a negative pressure to take in your next breath, and you can't do it because the lung is holding on to this air. So you're trapping air. So the next breath becomes shallower. So kind of how you described it here, the next breath is a lot harder, not because of anything that your airway is doing, it's because your lung is filled with more trapped air. All right? So you're stacking your breath. Okay? So the key is to let this air out. So you want the exhalation phase to be longer. All right? So you take a short breath, but take a longer exhale. Take the next short breath, take a longer exhale. Eventually, you'll be able to take a deeper breath and then exhale properly. So that's kind of maybe what we're talking about, but I would say that is the ultimate, physiology of asthma and an asthma exacerbation. And you want to just open up this airway so that this doesn't continue.
And basically that's what an inhaler does. It tries to open up that airway.
Open up the airway and gets rid of the inflammation causing that narrowing.
Right. You just drew that diagram, and actually the fact that you drew a diagram when I saw you was like, it kind of like made me think about how even you can, with any profession, you can have the knowledge, which is one thing, but then being able to articulate it, translate it, and even be a bit of a showman with it is what takes you from having knowledge to actually having excellence and actually being able to teach. And I think that what amazed me is, as soon as I came in, I think you had a few traits, and I'm going to have to apologize because I'm going to be kind of throwing dust in your face a bit here, but instantly I felt heard. I felt understood, because after you let me speak and get it all out, which you were very actively listening to, you explained to me what it is that I was feeling. Then you drew the diagram. And at that point, I thought to myself, I just felt instantly relieved. Because I thought, you know what, I wish I had seen a doctor sooner like this, right? And even like how I was kind of Googling like specialist, and I was just frustrated with all of the different opinions that I had. I was then put on a load of meds and nothing felt like it was working, and I was like, well, I need to find a specialist. That's how I came across you, right? And then, so then when I left, I was like Googling you, because anything, like one thing I know about doctors is that you could just like find so much information about them online. I don't know who puts it up there, but it's always there.
Always somebody who wants to fluff you up.
Yeah. But quite the opposite. I got a lot of great information about you and what you specialize in, and it was no surprise, or it was an aha moment when I saw that you were a professor, if I'm not mistaken, at the Michigan State University, right, teaching pulmonology.
Yeah, I was not a professor.
Okay.
I have to, the way it works is that when you teach at a hospital or you work at a certain hospital where there's residents or students, you become an associate professor.
Okay.
So it's not, I never officially taught at a university.
Fine.
But you become, it's just a title that you get.
Fine,
Yeah.
but you have taught pulmonology.
Yeah. I taught it as a fellow and as an attending. So I teach it to residents and students. So Sunday, for example, I'll be teaching it to 2 different students. Yeah.
I think that's what the aha moment was. I was like, you can tell that you teach it because you explained it to me, a layman who has no medical knowledge, so well. Actually, when I left your clinic, I spoke to, I rang my wife and I said, I just feel so relieved. Like I was still feeling the issue. I was like, mentally I feel so relieved because I felt like finally somebody understood what I was going through because you explained it. And I think that in itself is an art. Is that something that you've had to work on? Like having knowledge being one thing, but actually being a great doctor being like a separate thing?
I don't know. That's just a humbling comment to make. And I'm too embarrassed to even answer that question, to be honest with you. But it's an honor when you say that. So it makes me feel good. I will tell you, we all kind of most of us, we go through life with some philosophy. And when it comes to medicine, I think I developed it, I've been practicing for 20 years now. You realize that your goal is to teach the patient whatever is going on with them so that they feel more empowered. That's the goal every single time. And when you do that, they feel like, okay, they have the tools. They're not, running blindly. And it's true for everything, The second you give somebody the tools, right? You teach a man to fish, they'll fish for life. It's the same thing. We're in an age of information, and we have to, now be a little bit more liberal with the information that we're providing our patients, and kind of letting them know that, that it's okay, that this is something we're treating, this is what you can do, this is how you understand it, and ultimately, like you said, you make somebody feel better. You make somebody think about what's going on with them. I think it gives them a relief, even if it's a disease that they can't do anything about. They end up feeling at least a little bit more understanding of what's happening. Right? Like the common, prayers. Give us, the power to change what we can change, and if we can't change it, to kind of let it go. And so, how do I teach you to change and improve your asthma if you don't understand conceptually what's happening? So
one of the other things you said to me was that asthma is a friend for life. And if that's the case, and on the topic of kind of teaching your patients how to deal with it, what advice would you give an asthmatic on how to control this friend that they're going to have for life?
Yeah. So what I tell people, it's a friend you don't like.
Okay, fine. Yeah. So I missed that bit. That's a key part of the...
Yeah. You do not like Asthma.
Yeah. He's
He's a friend, but when he comes, you're not very happy. But he's a friend for life. He comes and he goes. You don't know why he came, and we welcome all people. You can say hello, welcome Asthma. I guess you're here. I have to deal with it, and so you want to let them know that this is how you deal with it. Use your inhaler, and when things get better, things calm down. The friend goes away, and you just wait for him to come and visit another time. It's kind of a joke, but I have plenty. I guess I gave you the friend one. Some younger kids, I say it's a monster that lives in your chest. I don't know if I told you that one, but that's
I think you said it's like a movie sequel.
That's right. They say the monster never dies.
Yeah, the monster never dies.
Yeah.
So how does somebody control it then in that sense, from a long-term perspective?
So he just has to know what the tools are. The tools are the bronchodilator. So the blue inhaler, but there's obviously many more inhalers. So you have a medicine that opens up the airway. You have a medicine that relieves the inflammation. That's the steroid. And you have other kind of supportive medications that might be too deep, but they're called biologic medicine. You have Singulair or Montelukast. So once you kind of know that it's an inflammatory process, you need to use something that has a steroid in it. So every time you get that inflammation, you got to use that inhaler with a steroid in it. To get the relief, you use an inhaler that opens up your airways. I think that's all you need to know. It's almost like, how do I keep my car running? Well, just keep the gas going and you're going to be fine as long as you understand that's the source.
Okay, so asthma aside, I just want to talk about breathing for a second. This sounds like probably this might be really come back to me as a really embarrassing question to ask. But for people even who don't have asthma, what is the correct way to breathe?
You inhale, exhale. It's believe it or not, if you're talking about people breathing through the nose, out through the mouth, I don't think there is a correct way. I think that the beauty of our breath is that most of us don't even think about it. Right. So if you're just breathing and you're just not stressed about it, then you're breathing right. The key is really, I guess, it's a good question, and I don't think there is a good answer for a correct way to breathe.
I think you gave a great answer, which is that you shouldn't have to think about it. Right?
You shouldn't have to think about it. I guess that's good.
That is a good answer. No, it is a good answer. Okay, so when I was reading up about you online, I was reading your kind of expertise. And the two commonalities I saw was kind of breathing, respiratory disorders or issues, asthma, pneumonia, issues of the lung. But then I also saw sleep being a big part of that. And that kind of kept coming up in your bio and in the different things that you treat. Is there a connection there between breathing and sleep, and then why is it that you became passionate about that as well?
Yeah, I'm very passionate about sleep medicine because I think there's so much into it. There's so much science and so much psychology about it, so much religion about it too. So I would say when we test your sleep, we're ultimately testing your breathing while you're sleeping. And so there's a different physiology that happens here. One is when you're awake, your muscles are nice and tense, and you're using accessory muscles to breathe. You're using all your senses. When you're sleeping, your muscles are relaxed. You're relaxed, your airways start to narrow. And in your deep sleep, really you're only using one muscle, which is the diaphragm, to breathe. And so your breathing becomes much more shallow. Yet so much of your rest comes from that sleep. So when you breathe, for example, you don't hear people snoring unless they're morbidly obese, right? People don't snore when they're awake. They snore when they're asleep. It's because the airways start to narrow, the muscles start to relax, and you start to your brain starts to kind of let go for a while and, process, the neurons very differently.
Are you saying that obese people snore while they're awake?
Well, you can hear them breathe.
Right, okay,
And,
understood.
you know,
and why is that? Because their airways are more narrow?
Their airways are narrow.
And
Their
why is
airways are
that?
narrow and kind of burdened by, you know,
Fats and stuff, okay.
fatty tissue. Yeah. So the guy who
Yeah,
would be just
yeah,
like
that makes
walking
sense. Okay,
around. Yeah, he's over, you know. And, you know, listen, it's no judgment for the obese person. I recognize it's a disease. So 100%, it's unfortunate, but, you know, there'll be treatments for them, hopefully. But the idea is, in general, you're not going to hear somebody breathing while they're awake.
Sure.
Yeah. So when they're asleep and you hear them breathing, you know that there's a whole different process going on, a whole different physiology going on.
I used to take a tablet called diphenhydramine.
Okay.
It was basically just Nytol, but instead of the herbal one, the one over the counter, right? And there's actually a big joke about it on this podcast for the long-term podcast listeners. They'll know what I'm talking about, because then I got loads of comments from people like, "Why are you taking sleep tablets? Still taking them?" So I didn't take them regularly. What I used to have a habit of. When I really don't like flying. I'm not scared of flying. I just find it boring. And so one of the things I would do as a habit when I was flying was take a tablet, knock out, wake up in the next country, right? And I would do that quite like whenever I flew, which obviously I don't fly every month, but I got to a point where I was like, this probably isn't a good idea, and I stopped, so now I don't take it anymore. But what's diphenhydramine like? Is that bad for you, or is it?
All right. So diphenhydramine is I think it's a first generation antihistamine. So you have like, you know, this second generation antihistamines, first generation. The first generation, they just, they blocked all histamine. So stomach and brain, and diphenhydramine was one of them.
What does that mean?
I think it's called
block histamine. What does that mean?
Basically, histamine is a neurotransmitter that builds up in your system.
Okay.
And I think maybe I'm misspeaking. So essentially, there's a neurotransmitter called adenosine, and
adenosine, isn't that the one that makes you feel awake?
Yeah.
Or makes you feel tired?
So I am actually trying to remember. So adenosine builds up in your system and makes you feel sleepy.
Okay.
And caffeine blocks adenosine. You are
Yes.
correct. Histamine is a totally different monster.
Okay.
So yes. So I apologize. See how smart I am. But no, histamine. You block histamine. Histamine, it will make you sleepy. And the problem with the first generation is that it has side effects that we are discovering are long-term side effects. And one of them is it can increase your risk for dementia. So you want to be very careful not to use the first generation antihistamines, even like diphenhydramine.
Wow.
So even for children who are having like allergic reactions, the first thing we did was Benadryl. And Benadryl in USA, I think, is diphenhydramine. And so it
is, yes.
Yeah, so you want to stay away from that. So the recommendation now is give them a Claritin or a Zyrtec or a Telfast, which are the second generation antihistamines.
What is it that, what are those brands here in the UAE?
Gosh, we have every single brand all over the world. Yeah, but
because my son seems to have a lot of allergies. Both of them have had croup here, and they've had to take him into the hospital, and they've had like steroid shot. Benadryl rings a bell, to be honest. But that's good information.
Yeah.
So first generation antihistamines, if you can, stay away.
Yeah. So most cough syrups, for example, they go, "Oh, doc, I want something that knocks me out." Well, usually they have one of the first generation antihistamines in them in order to just knock people out. There's a famous one here. What is it called? It's made in Egypt. It's called... starts with a B. I don't know. Now I can't remember what it's called, but people love it.
That happens often when you're on mic.
Yeah.
Like to me, I forget like basic words.
100%. I'm thinking to myself, I do this every single day. And right now I can't think of the term. Yeah.
Yeah, that happens all the time. Okay, that's really interesting. Okay, so my thinking was, just because I haven't seen an effect, like there's effects to everything, and don't just willy-nilly just take tablets and medicine and stuff like that. And so I was like, I don't need it. I'm old. I need to be careful as I'm getting older. I think having kids really wakes you up. When you don't have kids, you're like, oh, I'll just take a sleeping tablet. I'll do this. And you have kids, you're like, oh man, like I want to be around for these guys. You start taking your health a bit more seriously, right?
100%, 100%. You want to, because these things can make you sleepy throughout the next day also. Yes. That's the problem. Yeah, they can really knock you out.
When I probably shouldn't say this, but when I was at university, my housemate was had depression, like clinical depression. Sometimes he'd have from suicidal thoughts to mania, and so like sometimes I'd go into his room the next day, and I'd always go and check on him, make sure he's okay. And like sometimes he'd be on the floor. His sleep was very deep, but also at one point he got given these sleeping tablets that were like. And I had one, is what I was getting at, and they are serious.
They knock you out.
Yeah. You wake up with this metallic feeling in your mouth, but it's not. You don't wake up feeling good. You wake up with this metallic feeling in your mouth. You kind of still feel sleepy, and the way it knocks you out, it doesn't feel natural in any way. It's like you've taken something, just shut your body off. So
I wonder what it would be, but I mean, it sounds like I don't want to talk too much about somebody else, but maybe there's lots of SSRIs and medications that can affect your sleep. Mostly they do knock you out, but they change the pattern of your sleep, what we call the architecture of your sleep. So you might reduce the N3 sleep. You might reduce the REM sleep. So you end up with a lot of shallow sleep, but not enough deep sleep. So depending on what medication they took.
Okay, so REM sleep. You mentioned REM sleep. I was watching your videos. I was binge watching your Instagram channel. I saw a video of you talk about REM sleep, which you said, and I only know this now through your own video, is rapid eye movement. Which is amazing to me that's what it means. Because it's almost like, for, again, layman like me, you think, well, there's no link between eye movement and sleep, right? What was interesting to me about that video is you said that when somebody is in REM sleep, a normal person, a person who's like functioning like how they should, I suppose, in REM sleep, your body becomes paralyzed.
Yeah, 100%. Your body paralyzes pretty much every single muscle except your eye muscles and your diaphragm. So literally you flop. So you have kids. When they were first born, the vast majority of their sleep was probably REM sleep. So if you remember, they would be wide awake and they would go straight to sleep and they would flop. And that is their REM sleep. And the REM sleep is like a totally different sleep than all your other stages of sleep, because usually what you're doing is when you're looking at a sleep study, you're looking for these alpha waves and K complexes. Basically, your brain waves become much more organized and slow. All of a sudden, you go into this wavelength of like these brain waves that represent wake, almost looks like wake. The only reason the patient didn't wake up is because the muscles of their chin kind of weaken or flatten, so there's no tension in the chin, and the eyes start to roll back and forth.
So in this video, I don't know if you know which one I'm talking about, but you basically showed the results of a patient whose sleep you monitored to see, I can't remember what issue he was having, and what you had found was that he would move in his REM sleep, his leg would move or something.
Okay, yeah.
So I had a few questions there. One was, the main question was, how were you measuring that? So did you have a patient come in and then you just like hooked him up to loads of wires and then you let him sleep? Is that how you do it?
So it's interesting, the sleep study, because you're studying people's sleep and you think wiring them up the way we wire them up, they wouldn't sleep. So we're putting monitors on your brain to check your EEG. We put right next to your eye. We check your eye movements. We put like an EMG in your arm and your leg to see your extremity movement. And so we're looking for a lot of things. Lots of people kick in their sleep. Lots of people move around in their sleep. They have what we call, periodic leg movements. And sometimes it's a disorder, sometimes it's not. And so when you hit REM sleep, those muscles, those EMGs, you should not get a signal on them because they're in REM sleep. Their body should be paralyzed. So a lot of people who have, for example, like Parkinson's disease, or they have like neurologic disorders, or some people who are on certain medications, they end up moving in their sleep. And a lot of times you recognize that they have, what they call parasomnias. They wake up, or they don't wake up. They actively move in their sleep. They actively they act out their dreams in their sleep. For men, sometimes it can be pretty violent. They might have a partner next to them, and they would, maybe hit them, thinking that they're hunting. For example, we had a case when I was training. The guy was a veteran, and he would literally wake up in his, he would act out his dream in his sleep. He would think he is hunting a deer, or he's fighting a war, and his poor wife would be, a victim of his battering. He would wake up, have no memory of what it's happening. Yeah.
Wow, that's super interesting. I was intrigued by that with the REM sleep, but the other thing that you mentioned, I don't know if it was in a separate video, but it was related to a child who, I think you were connecting REM sleep and its movement, I might be wrong here, to ADHD in children. Or is there some connection between sleep and ADHD?
No.
I'd have to watch back the video and see what it was.
Yeah, so a lot of our kids are diagnosed with attention deficit disorder. So when it comes to pediatric sleep, it's a little bit different. So we have like REM behavior disorder, which is the term I was trying to think of. I don't know why I'm having trouble remembering, but I would say that's called REM behavior disorder. So you act out your dreams in your deep sleep. And just kind of as a going back to your first question, in like for men, our dreams can be very, hypersexual or hyper violent. And so when we act out our dreams, it can be quite scary. But for children themselves, a lot of times they say, oh, my child has ADHD. My child can't focus. My child has behavior problems. And a lot of times those behavior problems go back to how they're breathing. So either they have asthma and the parents don't know it, or they're not sleeping very well. So they move a lot in their sleep. So they can have what we call parasomnias. So they have night terrors. They wake up in the middle of the night. They have nightmares. So a lot of kids who are, diagnosed with these diseases or seen as, behavioral issues or ADHD issues, actually fundamentally have other issues happening. And I'll classically tell you, like, one of the very common questions I'll ask is, how's your kid doing in school? If somebody talks to them, can they pay attention for more than 10 seconds, or they become fidgety? And not because I'm looking for ADHD, I'm looking for any kind of sleep disorder or breathing disorder. Kids who don't sleep, who don't breathe very well, right? We talked about it in the beginning. If you're not breathing very well, you're not sleeping very well, right? We talked, our muscles relax, our airways narrow. So if I'm not breathing very well during my wake time, when I'm sleeping, I'm not breathing very well at all. Your brain is constantly sending signals into your head or into your body saying, wake up, you're not breathing. So the poor child can be in bed for 10 hours but not breathing very well during that time. Then they wake up, they're not focused, they can't pay attention, they're moody, all because they're not breathing and not sleeping very well.
You mentioned night terrors. I remember a friend telling me that his child was going through night terrors. What is that? Or what kind of things do you... What do you probe for when somebody says that my child's having nightmares or night terrors?
So often? Night terrors classically are happening in the beginning of the night. Okay, so we have 4 stages of sleep. You have N1, which is your transition sleep. N2, which is kind of your main sleep, like 50-60% of your sleep will be N2. Then you have delta wave sleep, which is your N3 sleep. And in that sleep, your child might have an arousal. They might wake up. Or they have a night terror. They might be asleep. I keep saying wake up, but it looks like they're awake. They're confused. They are hyper. They are scared. They are making no sense whatsoever. And it's usually happening early in the night because most of that delta wave N3 sleep is happening in the beginning of the night. And they are completely, inconsolable for a brief period of time. Okay, so it shouldn't last for a very long time, maybe 5 minutes, and then they go right back to sleep, and they have no recollection of them acting out their dreams or waking up or being aroused. But of course, the parents pay the price because they're very scared of what just happened. But ultimately, it's just them waking up or having an arousal during their N3 sleep. So it's usually in the beginning of the night, and it's usually during that form of deep sleep.
But is it like completely normal? Is it like a
Completely.
disorder? Okay.
I don't want to say it's a disorder. I don't want to say it's completely normal because it can be scary, but it has no real long-term health consequence.
Somewhere
the
between
kid is okay. The kid is okay.
Normal and disorder.
It's traumatic to the parents, definitely traumatic to them, and you want to be sure they're safe, right?
Yeah.
If they're on a bunk bed, maybe better idea to put them on a lower bunk because they might wake up and fall or something or hurt themselves. But ultimately, they're okay.
Because obviously, when it comes to children, you become more conscious, right? And this friend was saying, his daughter was saying she gets night terrors like quite often, and we don't know what it is. And I think parents start thinking along the lines of like there potentially being like a long-term disorder and things like that. But then why is it that some children have and others don't?
Good question. I don't think I have the answer. Yeah, lots of kids. I mean, there's bruxism, there's night terrors, there's nightmares, there's leg movement disorders. Yeah, some kids will have it. I think one of the, it is genetic, definitely. If the parents have it, we know like nocturnal enuresis. If one or two of the parents have peed in their bed when they were children, it's a good chance the child will have that too. So it's probably genetic. But I don't think we studied it enough. I mean, when it comes to sleep, let me just say, it's a form of medicine that we're really only scratching the surface of. I don't think before really the 1990s we were publishing much information on sleep or recognizing it as a medical specialty.
It's interesting because there's a guy called Will Ahmed. He has a product called the Whoop, which like prioritizes really like trying to understand for like a general consumer or a general person to understand their sleep better. As I don't know if you've seen it. It's a band you wear pretty much at all times, 24/7, and it gives you like a sleep score and stuff. But it's like quite a. It's not one of those. It doesn't seem like one of those fads. It seems quite detailed. But it measures things like, or it advises you to make your room cooler, and so is it that sleep is better in a cooler room and things like that. But I did you were speaking about children, I wanted to ask something that I think would be quite popular of a question. So that's to do with sleep training a child. There's so many questions I could ask about it. Essentially, when, how, or even should you ever sleep train a child?
Sleep train a child, like, can you describe it?
Let's say, for example, a baby can't sleep unless it's being rocked or can't sleep by itself.
Okay.
But at some point when the child is growing up, right, like in its very, very early years, maybe like before even being 1 year old, parents want to be able to get the child to sleep by itself. And there's like common theories on or practices. Like there's the cry out method where you just leave your baby and let it cry.
Right.
Some medical professionals say that's extremely dangerous. Others say that it's completely fine. They don't remember. And then there's different techniques. So I wanted to kind of dive into sleep training a bit, or any understanding about children's sleep.
Wow.
Babies, I guess, more than children.
So, I mean, there's like a couple of things that you have to think about. One is that you want the child not to associate certain kind of behaviors right before you put them to sleep, because then it becomes very difficult for the parents, especially if they have more than one child. So if you sit with the baby and rock them all the night until they fall asleep and then put them in bed, it's a guarantee that child is going to wake up. All of us wake up. We'll have an arousal in the middle of the night. That child is going to associate going back to sleep with being rocked. And if you don't go in there and rock the baby back to sleep, then they're going to cry and be miserable. So a lot of times you want to make sure what they are associating is something that they can handle on their own. So you want to kind of figure that out. Each child is a bit different, because some are, they're self-soothers. They know how to take care of themselves. Some, no, they need a lot of attention. So there is a lot of different varied techniques. I have to say, I haven't been training a lot of pediatric patients for a while, but we call it association type disorder, where the child associates a certain behavior from the parent in order to fall asleep. And then there is like, other things like their stimulation. You want to be sure you're not stimulating the child at night, or feeding them or letting them watch TV or their iPad right before they sleep. When do you do this? Every child is different. I think it's culturally different too.
Yeah.
There's nothing wrong. So when we were training, we would say, some people like to co-sleep with their kids. Some people don't like to co-sleep with their kids. Some people are perfectly okay with the child sleeping in the same bedroom and the same bed with mom and dad. Some people are not happy with it. So it really... I accept both kind of cultural variants, and whatever the parent wants is fine with me. Ultimately, it's the family that has the need to sleep separate from their children who have the biggest issue with it. Don't overindulge the child right before sleeping. Definitely teach them that there are kind of boundaries about their sleep. Prepare them, hey, 8 o'clock, it's bedtime, 7 o'clock, bedtime. And this is what we do. This is the ritual that we have. Once that ritual is done, you put them to bed, you walk away. And then based on how the child reacts, you want to react very, very, in a very limited way. So you don't want to overindulge them again and repeat the whole ritual again. You kind of come in, you talk to them. It's a surprise how much the kid understands and starts to figure things out.
I think also as they get older, that becomes a little easier. With you just met Zachary and Khalil, so Zachary is 4 and Khalil is 3. And with them, we have a bit of a routine. They know that bedtime is 7 o'clock. So like right now, you just heard all of a sudden everything's gone quiet, right? It's like they're being put to bed right now. So, around 6:30, we start the prep, brushing teeth, filling up the water bottles and stuff like that. And then they come upstairs. We'll go into the bedroom, turn the lamp on, and we'll read a book. After the book is read, go to sleep. And it's like they just get into that habit. And we found that having a routine is helpful as well. Sometimes in the middle of the night, they'll wake up and they'll try it. Oh, no, I need the toilet, I need water. Okay, have you water and go to bed? But generally speaking, we found that routine is really important. And then whenever we go back to, for example, London for like the summer and things like that, they just fall out of routine. And then it's a whole process getting them back into the routine again. They start playing up with sleep, right?
Painful. Routine is everything. And it makes the kid feel safe. I can't emphasize this enough. I mean, going back to psychology, when a child has a routine, sometimes I'm in the Dubai Mall and I see people with kids, running around. It breaks my heart.
At like 10 p.m., 11 p.m.
Yeah.
I'm like, how are these kids awake?
How? 100%. I feel so bad. I mean, look, I no judgment to any parent, but ultimately that kid
needs routine.
100%.
Is that
it's
just like
good
in
for
general,
mind.
not even just in sleep, just like in general in life?
100%. It's the one way the kid is going to feel safe. And they really do feel safe and secure when there's things that are predictable.
I never associate routine with feeling safe, with child feeling safe.
100%. Imagine your kid didn't have a routine. They're just running around all the time. You think that they are like free, but they don't. They actually feel lost. They feel, kind of sad. Maybe they grow up feeling like out of control. So 100%. It's really, really good for their psychology.
Are you a strict dad, knowing like this information? And stuff?
Oh gosh, don't ask my wife that question. I am
Who's
very weak.
My
wife, 100%. She is, she's the disciplinarian.
Oh, that's.
I want to think I'm the disciplinarian. I definitely have values, and I don't cross those lines. But no. They know to come to me if they want to break the rules.
That's cool. Okay. The other question: what is sleep apnea?
All right. So. Apnea, so I'm going to say it's Greek, and apnea is to breathe, and A is not breathing, so apnea is you're not breathing. And this is when you're not breathing in your sleep, 100%. And it is literally your body choking itself, because you have to understand a couple things. One is that you are not moving air for a variety of different reasons. Classically, because your airway, your oral pharynx is shut. So here is like your oropharynx, and then you go to sleep, muscles relax, but the airway collapses to the point where you can't take in a breath. You
and
are
that's the
literally
sound that somebody
choking
makes,
yourself.
and then they wake up.
But they wake up after 10, 15, 20 seconds. So I tell people that's the other thing. I mean, imagine yourself choking and your oxygen is dropping, your blood pressure is going up, your heart rate is going up, but you're still blocked. You're still not breathing. So we do not count in apnea until about at least 10 seconds of not breathing. So if you for 5 seconds, we don't count it. We don't count it. We don't consider that an apneic episode. Even if your oxygen drops 3 points, it has to be a certain period of time where you're literally not breathing. And your brain is now sending signals to your muscles going, wake up, wake up, wake up. So you have what we call a bit of an arousal. You have an arousal, then the muscles are signaled to tighten up. They open up, take a deep breath, and then your brain goes right back to sleep and you start choking again.
So I have so many questions. I never knew what sleep apnea was. So first of all, we have a distant, you could say like a family member who I remember now has been diagnosed with sleep apnea because my wife told me. And I've heard this person do that exact sound, like napping on the sofa. And now I'm thinking, that sounds really dangerous. So can sleep apnea kill?
So yes, the
End podcast.
the short answer is yes, but it's a slow death. You know what I mean? I mean, you can have sleep apnea for years and years and years. Definitely there are people when they are not wearing their CPAP machine and then they have heart disease, hypertension, kidney disease, and then they're having sleep apnea, 100%, you're more likely to have a heart attack when you die in your sleep, and you're more likely to maybe potentially die in your sleep. Now, I don't want to scare people. I don't want to like overwhelm them. Most of the time, sleep apnea kind of results in these comorbidities, right? You end up with high blood pressure. We used to say, oh, it's essential high blood pressure. Guy's 40, 50 years old, of course he's having high blood pressure. No, it's because he's not breathing very well in his sleep. He's not sleeping very well ultimately. They have heart failure because their heart has to now kind of compensate for the lack of oxygen going in. So your blood pressure goes up, your heart rate goes up. So people end up waking up with palpitations, getting atrial fibrillation. People get strokes. People have complications in their diabetes because, their hormones go out of balance, just to keep it simple. Cortisol level goes up, your blood sugar goes up, and all of a sudden you're waking up and your blood sugar is high. So it kind of contributes to the other health problems that you have. Beyond that, of course, if you're not sleeping very well, you're sleepy. How many people die because they crash because they fell asleep in their car? I mean, it happens quite regularly.
Is falling asleep in your car connected to if someone has sleep apnea, can they fall asleep easily?
So one of the criteria we use to justify the sleep study is your sleepiness. So we check an Epworth sleepiness scale, which is not super specific or sensitive for people who have sleep apnea, but we still ask these questions like, you're parked, you're in a red light, what's the likelihood of you falling asleep? You're having a conversation with somebody, how sleepy are you? How likely are you to fall asleep during that conversation? And we kind of determine on a scale, of 1 to 24 whether or not you're going to, how sleepy you are. And any number above 10 is you're very sleepy. And a lot of people will say, yes, I'm sleepy while I'm driving.
And that is a factor of sleep apnea.
Yeah.
Okay.
Or other sleep disorders.
Yeah.
Yeah.
I mean, so because this person that I'm thinking of, like, who has been diagnosed with sleep apnea, can fall asleep. Like, you're speaking to them, and it's like you just hear, you're like, oh, you're just speaking to me. What? Okay. So, how do you? Somebody comes in, they have sleep apnea. How do you fix that? Medicate that? Is it fixable?
I mean, there's...
Or what advice do you give them?
So, there's comorbidities, right? Being a male is a risk. You can't fix that. You getting older is a risk. You can't fix that. The only thing that there's physiologic kind of how your airway is structured, also hard to fix. So the main therapy ultimately is two things. One is weight loss, because we know gaining weight is a risk factor. So as we get older, I mean, we don't just gain it in our gut, in our butt. We also gain fat in our necks, in our tongues, in our mouths, in our faces, and that contributes to the apnea. So weight loss, 100%. I mean, there's a study just now came out about Manjaro, and it's how it can help cure sleep apnea. So sleep doctors might start giving this injection to their patients as well. But
are there do we know much about the side effects of Manjaro?
I mean, we know enough. I mean, we have like at least 5 years of kind of studies. So far, so good. So
really?
far, yeah.
It just seems almost too good to be true, right?
Yeah, I don't know, man.
Yeah, I'm not going to get you in any trouble.
Thanks,
You're going to
man.
say this is a doctor. We'll move on. And you said one is weight loss.
Weight loss, and then the other one is a CPAP machine. Which is, AutoPAP. PAP is positive airway pressure. So it's just airway kind of creating like a pneumatic stent into your airways, kind of keeping the airway nice and open, preventing it from collapsing. So that is the bread and butter. That's the mainstay of therapy for most people with sleep apnea.
It sounds like a lot of this can be fixed, delayed, reduced with just good general health. And one of the things that this recent asthma episode has done for me is made me say, I need to do more cardio. I don't know why, but I just feel like, okay, if I do cardio, I have better lung capacity. If I have better lung capacity, just maybe a tiny bit stronger at dealing with these kind of things. Am I thinking along the right lines?
So yes and no. One thing is kind of when you think along that lines, it's beautiful because you're thinking, I have to take care of my body. I have to take care of myself. And that's perfect. And people who are physically active, too much evidence shows that they are able to survive stress in their body in a variety of different ways. So psychological stress and physical stress. So no doubt, keeping a fit body is essential. I tell people movement is medicine. That literally. So I don't want to discourage that at all. But you also don't want to blame somebody for a problem that they have that, exercise and eating right is not going to fix, right? You have an immune response. You have inflammation in your airways. Nobody's going to tell you, running a marathon is going to get rid of that inflammation. You want to get rid of that inflammation through medicine. You want to give them an inhaled steroid, and, God willing, in the future, there'll be other therapies for them. But being fit is important, but recognizing where the problems are and fixing those problems medically is also necessary. You reminded me of a study I read a long time ago. I don't want to quote it per se, but I remember I think they followed soccer players or football players of Europe, and they followed them over 20 years. And they're of course, the fittest people you have. And none of them were complaining of shortness of breath, but they identified about 10% of these players as asthmatics. But they would run a pitch like it's nothing. And they're like, I have no shortness of breath. I have no problems breathing. I'm fine. I don't have asthma. They followed them over 20 years, and 100% of them ultimately were treated for asthma. Ultimately, they had asthma and they had symptoms and they needed inhalers. So no matter how fit you are, you can't really overcome a disease.
Fine. Okay. What about, so back to the conversation of sleep. What about pregnant women and sleep? Because it seems like there's sometimes insomnia with sleep, with pregnancy, and then at other times it's there just seems to be a lot of conversation around pregnancy and sleep in different ways. You got obviously the pregnancy pillow.
It's magic.
Any man knows what it's like having that in the bed with you. It's like having a third body in a massive pillow. What do pregnant women normally face when it comes to issues with sleep, and do you what kind of advice do you give them?
Gosh, I think physiologically they change, right? Okay. Estrogen, progesterone. So a lot of their hormones start to change. So they start to complain of certain things like insomnia. Unfortunately, a lot of it is difficult to manage because you don't want to give them a medication to help them fall asleep. So they feel less, refreshed from their sleep, or they might feel tired. A lot of women end up developing what we call restless legs. So it's a very common thing that happens in pregnancy, where restless leg has a certain criteria that it happens a certain time of the day. You have this unusual kind of feeling in your leg that you need to rub in order to feel better. You get up, you start to walk around, it goes away, and then you go lying back again, and then again that discomfort comes back. It's called restless leg syndrome. It gets worse throughout the pregnancy for a lot of women. Sometimes you have to treat them. You want to treat them with, if they're iron deficient, sometimes they become iron deficient. You want to give them, medication, iron, obviously, to help replenish their iron. A lot of times we can't give them any therapy because, the therapy is not safe in pregnancy.
What does a woman feel when she's got this restless leg syndrome? It's just like almost like pins and needles in the leg.
Like a very uncomfortable muscle sensation, maybe pins and needles, like an itch they can't get rid of. And it's a sensation that they have specifically at a certain time when they're lying down. They get up, it goes away. They move around, it goes away. And then it comes right back. Probably the most common sleep complaint in pregnancy, among other things, is the insomnia.
Okay. I'm conscious of time, so I'm going to round up in the next kind of 15 minutes or so. But I have a few things I want to go over. One of them is sleep myths, or like common things you hear about sleep. I want to get them G-checked by you,
Right.
or D-checked, the doctor checked, right? And then the other thing I wanted to do is kind of just delve back into the kind of the breathing thing, and a bit about like pneumonia and stuff like that, because I've had a recent understanding of it, which has kind of changed my perception. But let's start with the sleep myths. So there's a few things that have become popular recently on like TikTok, Instagram kind of vibe. One of them is mouth tape. Apparently you should be a nose breather, and there's like a lot of companies now who have like created this like sleeping mouth tape. You can tape your mouth up while you sleep so that you can breathe through the nose. To me, it sounds really dangerous. Is there any kind of like anything to back that, the whole kind of taping your mouth when you sleep thing? How does that sound to you?
I didn't hear about taping your mouth while you sleep until last month.
Okay.
But what I can tell you is when you close your mouth, what happens is you do increase the tone of your soft palate and your muscles in your mouth. So there is some truth to the fact that the tone inside of your airways does increase. But 100%, I would not recommend it. So you take a little bit of truth and then you kind of go with it, and you convince a whole group of people about it. There's a lot of stuff about I don't know if you're going to ask me, but that nose bandage for sleep apnea. I mean, that doesn't work. Not for sleep apnea. Yeah. Okay,
that was one of them. Another one was blue light blockers. I've heard people say blue light blocking glasses, they're not that effective, and some that say they are. I think people try to block out blue light before bed so that they're more sleepy.
So there is a lot of kind of research with blue light, and for what do they call it, jet lag, traveling, and helping kind of reset people's circadian rhythm. There's not enough science to kind of explain. To give you a good answer.
Fine.
So, but it does affect your sleep. It does kind of train your brain either to advance your sleep or to delay your sleep. So we know that that's true. Do I understand the science well enough to kind of give you 2 cents? No.
Okay. White noise machines.
They work. Yeah, white noise machine work for a lot of people. I think it works for a lot of people who suffer from trauma, bringing psychology back, 100%. White noise machine is something there to help somebody feel safe.
And do you use a white noise machine?
No. I don't use anything. I don't know. God bless me.
You're too tired.
I just close my eyes and then I don't know. I wake up the next day. It's fine. Yeah, mashallah.
But are they dangerous at all though? Like listening to something all night?
No, it's fine.
Okay.
You're talking about white noise machines?
Yeah, white noise machine, yeah. It's funny because I didn't know about white noise machines, obviously, until I had a kid. And then, we started playing some white noise. And then we kind of was like, we found that even when the kid wasn't there, we were turning the white noise machine on. So it does, you do get a level of comfort from it that...
it provides some sense of safety for some reason.
Yeah, it's interesting. Yeah. Okay, fine. You need 8 hours of sleep per night.
So for the majority of people, this is 100% true, and it's very important to understand. There's such a thing as too much sleep, and there is such a thing as too little sleep. I mean, I think internationally we recognize that, torture includes sleep deprivation. So we know how important it is to sleep. Now, how much sleep do you need? That can vary among people. I don't want to say across the board. So there are people they're called just short sleepers. Throughout high school, they slept 5-6 hours and they felt fine. They functioned fine. They're doing okay. Throughout their adult life, they sleep 5-6 hours. They might have a partner, like a wife, who's miserable. Like, why does he not stay asleep long enough? But the vast majority of people, you need to hit that amount of time. Too much is a comorbidity. It can increase your mortality, and too little increases your mortality.
How do you prioritize sleep?
What?
Do you prioritize sleep for yourself?
100%. Like anything else, like my job, like anything else, sleep is a must. For me, I pray my night prayer and I go to sleep and I make it a priority.
Okay. So you sleep quite early?
I do. I'm not a late guy. I'm definitely not a late.
No,
I was not like a party guy. Only because I like to sleep and I like my time in the morning.
Yeah, I'm a morning person. I like to go to bed. I love going to bed early. If I can be in bed at like 9:30, I'm there.
I'm with you.
So do you try and get 8 hours yourself? Or?
Yeah, 8 hours, 100%. You can't function very well the next day. Now, school started, right? And I take my son to school. Likewise. And I have to wake up early. I don't function as well. I forget things, and I'm maybe more short with people, just because I know I didn't sleep very well.
I'm like you, man. I do the school one in the mornings, and in the UAE, it's something a bit different to the UK and perhaps the US. School starts a lot earlier, and so you have to have a good night's sleep, because if I have a rough night's sleep or I don't sleep early enough, it's actually dangerous, because my drive to school is about 40 minutes in the mornings, and I could have chosen a closer school, but I didn't. I like this school, but doing 40 minutes of driving, like, I need to have a good sleep. I need to have my coffee in the morning before I hit the road.
I'm with you. Yeah,
it's
totally okay.
Yes, you get too sleepy. I wanted to ask about the Sunnah. So we know, like, in the Sunnah, we have a lot of information about like pretty much every aspect of life. And one of the kind of things that comes up a lot is how the Prophet Sallallahu Alaihi Wasallam would sleep.
Yeah.
Have you, in your study of sleep, found similarities? Like, for example, the Prophet Sallallahu Alaihi Wasallam would encourage not sleeping on your stomach or sleeping on your right side. I'm sure there are other things that I'm not too knowledgeable about, but have you ever in your study had kind of like one of those aha moments of like, oh, like there's a direct link there?
Yeah. So I really want to qualify myself as not a scholar. So I would tell you that no, I have not found anything in particular. We know, for example, sleeping on your back worsens generally for most people your sleep apnea. Sleeping on your stomach, we don't find any kind of particular increase, abnormal outcome in your health. And sleeping on the right side or the left side, some people actually do better on the right, some people do better on their left. Literally, their oxygenation, their heart rate is better on the right, and their oxygenation is better on the left. So there might be kind of a spiritual value into whatever, the Rasul, the Prophet recommends. But, as far as the science is concerned, I'm not aware of any kind of link. I'm not aware of anything.
And when you're doing the sleep studies, when you're wiring people up, are you even checking for things like their position during sleep and stuff like that?
Yeah, 100%.
Is somebody watching them all the time?
Yeah, you're on a camera. Most of the time, there's a camera watching you and recording you. Yeah.
That's cool. How many of those do you do? Is that like a regular thing?
We do like 10 a week. Yeah.
That's really interesting.
Yeah. I love it. It's so interesting.
Things like that I would be interested in just doing for the sake of it for myself, just to get more information about how I sleep and stuff. But then don't people sleep in different ways in different parts of their life? Like if you're going through stress at work or...
Yeah. You get more interrupted sleep. If you're under stress, your architecture changes. You have more arousals. You can't maintain sleep. We have something called insomnia, which is I can't sleep, but there's a variety of different insomnia. It's like you can't initiate sleep. Some people can't fall asleep. Some people can't maintain their sleep. Those are people, sometimes they're under a lot of stress or depression. They just wake up and, their brain gets activated and they have a hard time falling back asleep. Yeah. So it's very interesting. Like when you hear the complaint of the patient, I have a great case where the patient, she says, I can't stay asleep. I go to sleep, I wake up, and it takes me 2 to 3 hours to fall asleep. And so literally she goes to sleep. 2 hours later, she wakes up. It's definitely an arousal. It definitely wakes up. And then 2 hours later, she falls back asleep. She's not aware of what's happening, but she was having seizures. We diagnosed seizures from that. So it was very interesting.
Wow, that is
yeah.
interesting. Okay. Just lastly, before we end the podcast, I do want to speak a bit about pneumonia, because again, snooping through your content, I did see that you were showing an X-ray of somebody who has pneumonia, and you were showing how you found it through the X-ray, which I found incredible. I didn't really see pneumonia as anything that I could as something that even people go through, unless my understanding of pneumonia was essentially, if you get really cold, you can get pneumonia. Right? That's all I knew of it or thought of it.
Yeah.
So I'm like, well, I just won't put myself in those positions, situations, right? Like I thought if if it's snowing outside, like it does in the UK, put on a coat or a jacket, right? And you just protect yourself from pneumonia. And then I had a meeting with somebody when I was in the UAE, and they were telling me about how they had pneumonia, and this was a young person, and it really surprised me. And they were saying that they kind of had a bit of a misdiagnosis, but then they ended up getting diagnosed and it was pneumonia. And that they now use, and then they were using a nebulizer to help them as well, and they use that often now just to keep going. But they said that, two things surprised me. One, that this young person got pneumonia, and so I'm intrigued as to kind of how wrong was my thinking of just like, as long as you don't stay cold, you'll be fine. And then second of all, they said to me that they found out that pneumonia comes in threes, or twos or threes, and then they got it again, and then this is what somebody had told them, and then it did happen. So I just want to know a bit more about pneumonia.
All right.
Really baseline for the layman, like what it is, my thinking behind it, and some understanding of it.
So there's a lot of different types of pneumonia. Classically, it's an infection of the lung, okay? And there's two classic popular infections. One is bacterial infection, the other is viral infection. And remember, like you breathe in, you breathe through your mouth, breathe in through your nose. Everything from the environment is open to your lung, right? So your immune system is cleaning all the time. Everything that you're breathing in, your immune system's cleaning out. Every once in a while, a bacteria, a virus gets through and makes it to your lung. I don't think anybody will live a whole life without getting pneumonia. So it's a very common disease,
Really?
And we survive. Most of us survive. It depends on the infection. But it's an infection somewhere in the airway. Now, pneumonia is infection of the lung, so we call it the lower airway. So here's your trachea right here. Anything kind of below that, we'll call that pneumonia. It can be bronchial pneumonia, it could be lobar pneumonia, or something in between. Like, when COVID happened, you got pneumonia. It really affected the alveoli. You got this alveolitis. You couldn't oxygenate. So ultimately, it's you being exposed to a bacteria. That bacteria or virus found its way deep in your lungs and caused you to be sick. Now, this thing about twos and threes I've not really heard of, but we do know that you can get super infections. So influenza, very classically, people, doc, I got the flu. And that flu goes into your lung and creates havoc. But also kind of, builds a road for the next infection to come in. So it kind of weakens the immune system, for lack of a better term. So a lot of people who get like influenza, RSV, they end up with super infections of the lung. And so one week they have influenza pneumonia and they can't breathe and they're miserable. They recover, and then 1-2 weeks later they become sick again. They have a super infection, like of what we call streptococcus or staphylococcus, classically, pneumonia, where they need an antibiotic to take care of that infection. So to keep it simple, it's not the cold, it's just your exposure. So why did I fist bump you when I saw you today? I just saw a bunch of sick patients, I don't want to make you sick.
Yeah.
So we have something called like fomites, like things that the bugs are carried in. And those bugs kind of like, you know, their mode of transportation is the fomite, and then they go in through your nose and kind of crawl down your airway and make you sick.
Yeah, so you mentioned, I saw online that you're I don't know what the word is, qualified to deal with emergency cases. And then I also remember the other day when I came to see you that the nurse had said that you had gone to an emergency situation and that you'll be back in a few moments. What is an emergency situation that you would deal with in your field? Like what kind of thing would be happening where you need to go and deal with an emergency?
I mean, there's too many to count, but ultimately, when it comes to pulmonary, we have two vitals, right? Your respiratory rate. Somebody just can't breathe. They're breathing really fast. They're not ventilating very well, and they might need to be intubated. They might need to help get some artificial support to help them breathe. And sometimes their oxygen drops. Like all of a sudden, they're 95, 96%. All of a sudden, they're 70%. And they're turning blue, So we get those often, and pneumonia often is one of the reasons for that. So, yeah, I mean, life-threatening. I mean, there was this thing, I still think about it all the time. I know it happened in Jordan, but it can happen anywhere in the world, where a whole hospital lost oxygen. They didn't have any oxygen during COVID. So all of a sudden,
for the nebulizers,
not just for the nebulizers, just to give people oxygen. So people were surviving on oxygen during COVID. Their oxygen was dropping, and we just supplied them with oxygen until their body healed on its own. And oxygen ran out. There was no oxygen. People died. And India, there was a time when they were short on oxygen. So yeah, those are the emergencies where somebody needs oxygenation, somebody needs help with ventilation.
You must have been a busy man during COVID.
Oh my gosh, COVID. Yeah, that was trauma.
Oh man.
That was trauma to the brain of every doctor, I think. Yeah.
But like every doctor, but pulmonology, right? People were struggling to breathe.
100%. It was, we were right at the center of it. People were, coughing at me all the time. I'll be honest, there was a point where I don't even know why I'm wearing the mask anymore. I'm like, I wear the mask because I had to wear the mask, but I didn't think it was really making much of a difference.
You were at the same hospital at the time?
I was not this hospital. No, I was at a different hospital. Yeah.
Oh man. Dr. Fawzi, thank you so much.
It was a pleasure, really.
Honestly, there's so much more that I could dive into with you, but I'll let you be this time.
Thank you.
And I'd love to have you back on. It's been an absolute pleasure to have you on. Thank you so much for giving us your knowledge. Also, on a personal basis, thank you so much, for giving me a lot of reassurance and advice too. So,
it's a big honor. Thank you.
Yeah, it'd be lovely to have you back on in the future sometime, inshallah.
It'd be a pleasure to see you, and thank you for inviting me. Well, I've actually never done a podcast before.
How did you find it?
I thought to myself, it's worth it. Very interesting. Very interesting. Now all of a sudden, I know what it feels like.
Yeah, I mean, we spoke for I don't know how long, at least maybe an hour and a half. So time flies, right?
Oh, really? It's been that long? Yeah, I'm surprised. Oh my gosh, you were right.
Yeah. So no, I've really enjoyed it. Thank you so much for your time. And
thanks, Faisal. Well, thank you very much.
All right.